Good evening, everybody, and welcome to today's session. Today, January 22nd. I'm very excited. Tomorrow early morning, I'm flying to Dehradun from Hyderabad to be at the Government Doon Medical College. And evening in the lecture gallery, I'm going to make a large crowd of students experts in the topic of ECG in 3 hours. So before I fly, I thought to all my students across the country, let me have an opportunity to discuss few questions today before I wake up early morning to run around to Hyderabad to Dehradun. If you are from Dehradun, please do attend the session. It is at evening 5 p.m. at the lecture gallery 2 in the Government Doon Medical College, Dehradun. Good to see around 10 online classmates. This is Dr. Murali Bharadwaz once more, your classmate, your roommate, your study mate, WhatsApp mate, to help you to become the NEET PG topper. Studying with you every day is a great pleasure and the only thing I enjoy in my life. Mohan Sharma and many more who are all online. Now, doctor, one of the very common questions, common challenges for many students is the big or. What is the big or that you know, doc? Can you tell me what is a big or? Yeah. Yeah, what is a big or? Or for revision. Whatever you study, doctor, last moment, are you able to revise or not? If you are able to tell me that, yes sir, if you give me 10 hours, I can finish gynecology. If you are able to say, that means you have prepared very well for the exam. If you say, no sir, I require at least 1 month in my schedule to do the revision in gynecology, no, you have not studied. So, the whole knowledge, whole preparation that you are doing now in January, today is January 22nd, say, January 22nd. If you are taking FMGE, your exam is there in June. If you are taking the AIMS May, it is there in May. If you are taking the NEET PG 2021, it is another 11 months ahead. But whatever it is, how do you know that you have revised the subject thoroughly? How can you say that you have revised the subject thoroughly? The taste of the pudding is the best test of the pudding. You know that? So, if you can revise the subject in 10 hours, each subject in 10 hours, whether it is medicine, gynecology, obstetrics, dermatology, I don't care. But if you can consolidate the entire knowledge within 10 hours, you are able to do the revision. That day, I'm going to tell you that you have thoroughly prepared for the exam. So all my job, doctor, is how to make you such a focused guy in your preparation so that you have your own set of points on every topic so that tomorrow you are ready to face the exam. So the best way to inspire anybody or to teach anybody or to drive anybody is basically to show anybody as to how to do it. I'll give you one classical example taking few topics in gynecology and how to briskly revise, how to make notes that in the last moment you are able to use it. That is the objective of our today's session. Good to see Kirti Pawar, Mohan Sharma and many more who are all online. Thanks for joining with such a short notice. Now, cervical pathology. A 34-year-old woman, post-coital bleeding, speculum examinations shows cervical ectopy. A very common question asked by the examiner is, what is the next best step do you want to do? Dr. Jivago, what is your answer? Cervical smear is what you want to do. If the cervical smear shows inflammatory changes, what are the recommendations? I hope the monitor is broad enough for all of you. Yes. You repeat the smear after 6 months and you take the swab and then you treat the infection. A good number of times cervicitis is infectious in origin, right? Now, a 40-year-old woman, offensive bloody discharge, ulcerated cervix. If you touch, it is bleeding, it is friable. They are the classical hallmarks in the clinical vignette. Tomorrow in the NEET PG exam, bleeding on touch, a friable lesion, ulcerated cervix, offensive bloody discharge, typical 40-year-old women, only think of cervical cancer. It should strike to your mind. Is my voice loud and clear for everybody? Can you please punch? Without any echo, you are able to follow my voice, right? Now, can you please punch whether the voice is loud and clear for all of you? Now, metastasis of cervical carcinoma. Typically, we do the CT scan, whereas metastasis of endometrial cancer. Endometrium is a lot of soft tissue detail that you need to go through. MRI scan is the one which is preferred. Now, doctor, if there is a moderate versus mild, moderate, severe dyskaryosis, how do you want to do? What do you want to do? This is the favorite, what is the next step in management? This kind of a question. So, mild, moderate, severe dyskaryosis, you will be doing colposcopy. So, doctor, lot of times students have a challenge. They are not very sure how to make the notes. Let me tell you, the purpose of making notes is, in one line you should be able to tell, or you should be able to do the revision of that crucial point that you are studying. So that is the reason, be very sure how to make brisk notes and do a quick revision in the last moment before exam. You should be very, very sure about. So mild, moderate, severe dyskaryosis, colposcopy. Moderate dyskaryosis, colposcopy within 4 weeks. Then if you take the cervical cancer, doctor, family history is a risk factor, and in cervical smoking is a risk factor. That's what you need to remember. Now, doctor, we come to a very important area for which all the gynecology department is being created. What is that? Menstrual problems. What is a very common question asked in the examiner? How do you do a differential diagnosis of primary amenorrhea and secondary amenorrhea? Earlier I made a video that explains you how to dissect the problem of primary and secondary amenorrhea. See, doctor, gynecology, obstetrics, Unlike general medicine, there's a very little to do the reasoning. It's a lot of facts. A surgeon is all about facts, and a physician like me is all about talking, right? So, but still in gynecology, there are areas where there are algorithms, especially where endocrinology plus gynecology is combining. So those areas you need to know how to do the reasoning, differential diagnosis, and face the clinical vignette based MCQs in the tomorrow's NEET PG exam. So doctor, primary amenorrhea, cyclical lower abdominal pain, you should think of imperforate hymen. Obviously, when the hymen is imperforate, there is a lot of bleeding which is collecting behind it, which will be responsible for the cyclical lower abdominal pain. Then, if there is a hyperthyroidism, patient will have oligomenorrhea, tremors, palpitation. If that is there in the clinical vignette of the examiner, do thyroid function test. That should be your next step in management. Slowly, NEET PG is also becoming like United States Medical Licensure Exam, USMLE. So you should also tune your mind whether it is a next exam in future or NEET PG. We should all be ready to face the clinical vignette based questions. Now, lactational amenorrhea. After the breastfeeding, there is a high prolactin which is responsible for the lactational amenorrhea. Now, a typical history will be given to you in the tomorrow's exam, doctor. Patient is having a lot of perimenopausal symptoms. How do you want to manage? Flushing, mood swings, etc., etc. Your answer should be reassure. Reassure, doctor, not the antidepressants, not the mood stabilizers. That should be your answer. There is primary dysmenorrhea. Dysmenorrhea means pain during menstrual cycle. There is no cause found. How do you want to treat? What is your next step in management? The examiner is going to ask you. Mefenamic acid is considered to be the most important part of the treatment. Menorrhagia with contraception. If you are using contraception, there can be menorrhagia, excessive bleeding. Typically, intrauterine contraceptive devices have a greater tendency than the combined oral contraceptive pills. Now, there is a heavy menstrual bleeding. The patient came to you in an exsanguinating state. What is the next step in management is what examiner is going to ask you. What is the acute treatment? You want to give antifibrinolytic agent. Antifibrinolytic agent, and that would be the tranexamic acid is what you need to remember. Now, doctor, pelvic mass. Old women, abdominal bloating, frequency of micturition, difficulty in defecation, ultrasound is showing cystic and solid areas which are rising from the left ovary. There is a free fluid in the pouch of Douglas. After the examiner told all these things in the clinical vignette based question, if you can't make out ovarian carcinoma, doctor, examiner will commit suicide. So be very sure about it. Right? So that now, right ovary, complex, solid, cystic mass on ultrasound. When the examiner says that, think of dermoid cyst, which has such a kind of a sonographic appearance. Young lady, dysmenorrhea, dyspareunia. She has a lot of pain and moaning while having intercourse. Infertility, Tenderness, if you are trying to do an abdominal pelvic exam, ultrasound is showing a right-sided cystic lesion with numerous echogenic areas. That is the clue, doctor. In the clinical vignette, you should jump and answer endometriosis. There will be no time in the exam. These are all very standard clinical vignette, next up in the management kind of questions. You have to be very sure. Reading is different. Applying this logic and solving the MCQs in the tomorrow's exam, which are clinical vignette based, you should be well prepared for that. So doctor, young lady, dysmenorrhea, dyspareunia, infertility, tenderness on the abdominal pelvic exam. Wow, 001. These evening sessions, I love them, doctor, right? I love them because of two reasons. I love them because this gives me a chance. Sitting in a home or an airport or a hotel room, I am able to talk to you wherever I am, right? Thanks to the YouTube and the wonderful internet in digital India. I'm so proud of you, 001, right? That you are able to crack the FMGE. So I always feel, if I can be able to add a little inspiration to you every day, and you are able to get inspired to go back and consume the online video library on the onlinembbs.com. If our combined interaction and constantly pumping you with questions in the WhatsApp study group where you are present, if that is able to add that required petrol and ignition to your preparation, yes, I can say that we are the best digital medical education. Modi ji ko hum likhna padega that across the country freely we are able to meet every day and enjoy just because of a good internet speed. So thank you very much once more, 001, for giving me this wonderful result. And जरा एक छोटा वीडियो बना के टेस्टिमोनियल भिजाओ. I fully agree. You got a top rank because of your personal effort. There's no doubt on that. But still, success has many people who claim it, right? So please give us one opportunity to claim that we are also contributory for your winning the game, right, Doc? So I'm so proud of you and thank you so much. Now, doctor, yes, acute pelvic inflammatory disease, how does it basically present? Yes, acute pelvic inflammatory disease, how does it basically present? Abdominal pain, dysuria, vaginal discharge, tender lower abdomen, vague mass in the left iliac fossa, inflamed cervix, purulent discharge, unprotected intercourse is a risk factor. If all these things examiner is putting like badam, kismis in the laddu, you should recognize that it is laddu. That is all about the clinical questions in USMLE pattern in NEET PG and FMGE exam, right, doc? Now, high temperature, lower abdominal pain, past history of pelvic inflammatory disease. Where to make testimonials, sir? Thank you so much. 9000868356. Our helpline number, doctor. Please record a small video in your own words, honest words. What is good? How we can improve in helping you guys? what more we can do to help you to improve, and a little bit on your story, that which university in China that you have, or Russia you have gone to, what were the challenges for a foreign medical graduate, and how you are able to surpass all those things. Of course, one last word, East or West, Dr. Murali Bharadwaz sir is the best. एक ऐड करो, हम बहुत खुश हो जाएंगे. We will have a good night's sleep. So you can send a small video to 001. You can send it to our helpline WhatsApp number. Right, doc? Now, ultrasound. Wow, Nagesh. One more firecracker. Nagesh is also able to crack the FMGE. Excellent, doctor. You all guys should join our, continue to be in our game to also give similar kind of a good results and a good news that you made it to happen in the FMGE exam and in the future for the NEET PG exam also. Thank you so much, guys, for making it happen. What is that in Hindi? What do you call? Hum kamyab banke dikhayenge. That should be the goal, right? So you are giving me the same feeling of Super 30. Super 30 में last scene में Hrithik Roshan को देखे तो मुझे I am unable to stop. I started crying uncontrollably in the movie theater. So you are all guys giving me a similar kind of a feeling today, doctor. I am so happy. Now, tubo-ovarian abscess, high temperature, lower abdominal pain, past history of pelvic inflammatory disease. Ultrasound is showing cystic and mixed echo pattern, that is tubo-ovarian abscess. Torsion of the ovarian cyst, how does it clinically present? Acute sharp shooting pain in the right lower abdomen. Patient is having vomiting, right? So typically right means it can be left or right anywhere, but we want to point out that it is unilateral, typically. Unilateral, single side, and typically periods 3 weeks ago. Ultrasound is showing a cystic mass in the right adnexal area, and there is an absent flow on Doppler. They're all the classical appearance of torsion of ovarian cyst. Now, doctor, we come to a very interesting area, urinary incontinence. Typically, examiner will give you a history. After hysterectomy, patient is found that she is wetting herself continuously. That is a very important clue. You should think of ureterovaginal fistula because of the hysterectomy. Now, a obese woman presenting with incontinence, whenever she is laughing, sneezing to the jokes of her granddaughter, think of stress incontinence. Weight loss and Kegel's pelvic exercise is going to help her. So today my intention is how to make your own personal notes. Whether you are attending any coaching program or attending any videos on the apps, anything you are doing, your own notes, your own thought process on, in one single line, how can you be able to consolidate the whole gist of the facts that the examiner is going to ask? That is the most important talent. You guys tell me, in 10 hours, sir, I know how to do a revision for myself and to my roommate also. To my roommate also, I can make him Gyani in gynecology, Gyani in obstetrics in 10 hours, medicine in 10 hours. anatomy in 10 hours. The moment you are able to reach that level of perfection and consolidation, obviously you are going to crack the entrance exam, doctor. Even you don't need any mock tests, right? Now, a old lady, she can't hold the urine. She leaks before she reaches the toilet. She's running. Oh my God, already drops of urine started pouring out. Even before she reached the door of the bathroom, it is urgent incontinence. So, what are you going to do? Bladder training. Oxybutynin is the one which you will use for urgent incontinence to decrease the spasmodic contractions of the bladder. You give oxybutynin, and she need to maintain one bladder diary. Bladder diary is what you should remember. Now, doctor, let us talk quickly about how to make notes on miscarriage. Obese, hirsute, miscarriage. Think of polycystic ovarian syndrome. There is a miscarriage in second trimester. It is unlikely to be caused by any congenital abnormality, because all congenital abnormalities due to the underlying chromosomal abnormality like Down syndrome, Turner syndrome, etc. Miscarriages are all in the first trimester. Recurrent miscarriages early in the first trimester. If you have forgotten to get the APLA, antiphospholipid antibody syndrome, antibodies, patient is going to sue you in the court of law. So be very sure about it. Now, doctor, cervical incompetence. What are the 5 very important points that should get into your notes? Recurrent pregnancy loss in the second trimester. There is history of premature rupture of membranes, early dilatation of the cervix. These are the clues to say that examiner is looking for you to answer it as cervical incompetence. So which antibiotic do you want to prefer, doctor, if you want to treat? Prophylactically, what antibiotic you need to give in case of premature rupture of membrane to avoid the development of chorioamnionitis? Your answer, you should jump and say, metronidazole is my first choice. Whether you are in London facing MRCOG exam, or whether you are in USMLE step 2, or whether you are in NEET PG or tomorrow next exam, your answer is metronidazole. Now, patient is having APLA, antiphospholipid antibody syndrome. It is a prothrombotic condition. Examiner will ask you, what are the things that you want to add? What is the protocol? What is the protocol? What are the things you want to add in a case of APLA syndrome? At the time of conception, aspirin. And you need to add heparin at 5 weeks when the fetal heart sound is heard. So that is the important part of the protocol. Now, a large fibroid is causing recurrent miscarriages. What do you want to do, doctor? Examiner is going to ask you. Myomectomy is the treatment of choice. Similarly, the patient had the first miscarriage. What do you want to do? Reassure. Reassure her in abundance is considered to be most important part of the management. Now, doctor, presenting to you in the outpatient department in gynecology, this young lady with vaginal discharge. How are you going to clinically approach? If it is a gonococcal cervicitis, uncomplicated, then ciprofloxacin. If it is a gonococcal cervicitis complicated, ceftriaxone should be your answer. You'll remember, right? These are all very stock questions, stock answers. Please join our WhatsApp study group. Please give a call to 900868 I will make all these handwritten notes and quick bullet point notes made available to you when you are part of our WhatsApp study group. So if you are not yet a part of our study group, WhatsApp study group, please call 900868 We have 20,000 students. Every day, hundreds of students joining our WhatsApp study groups. And you get a lot of inspiring company like 001, Nagesh, and many more who are cracking the exams. That is most important, doctor. Ultimately, how to read less, how to do revision, how to consolidate. Assume that if you are having exam in January, no doctor, don't think you have December. Think that you don't have December. You think that there's an earthquake under your feet in December. So don't count December. Prepare as such you have exam on December 1st only, not January 5th. If you are approaching like that, then once more, you will read. But ultimately what will happen, doctor? 1 month before exam, you will find lot of spiritual gurus on internet. How to crack before 1 month, this is the way to crack, do gymnastics, dance like a orangutan, you will be able to make. No doctor. 1 month before exam, this kind of personal notes that you will be making, no doctor, that is the one which is going to really come handy. And if you are able to do a revision in 10 hours, end to end of the subject, then you have really prepared for the exam. That is the only secret of the last 1 month. Now doctor, chlamydia cervicitis, how do you want to manage? Azithromycin, more preferred than doxycycline. Pelvic inflammatory disease, metronidazole, doxycycline, 2 weeks. That should be your answer. Then if there is a urinary tract infection with chlamydia, one of the favorite questions of the examiner. Chlamydia, UTI. Single dose of azithromycin, 1 gram stat to each partner, hubby or boyfriend and his sexual partner. Both of them should be treated. There is a vaginal discharge, fishy odor, but what is the important clue to point that this is not baby candida but it is bacterial vaginitis? No itching, no itching. Vaginal discharge, fishy odor, no itching, then that is bacterial vaginosis. Cardi vaginal discharge, intense pruritus, doctor, I can't bear this, doctor, that is candida. Topical clotrimazole, single dose fluconazole. Topical clotrimazole, single dose fluconazole, that is your treatment for the vaginal candidiasis, is what you need to emphatically remember. डॉक्टर साहब उल्टी हो रहा है, डॉक्टर साहब मुझे ये प्रेगनेंसी नहीं चाहिए, डॉक्टर साहब मैं जिंदा नहीं रहता हूँ, डॉक्टर साहब मैं मर जाऊंगा, डॉक्टर साहब इतना उल्टी हो रहा है, डॉक्टर साहब आई एम फीलिंग सो मच nausea, I don't even looking at the face of my husband also I am feeling like vomiting. Of course, a pregnant woman with that hyperemesis gravidarum, oh my God. You should see one patient in OP and listen to her story. You will never forget in life. Main challenge of hyperemesis is dehydration. Admit her and give IV fluids. Very important. Molar pregnancy. How do you want to manage? I mean, typically is the one you should always suspect. If there is a hyperemesis gravidarum, large for date uterus on examination, when you see this combination, think of molar pregnancy. Then, if there is a space occupying lesion or a brain tumor, if that is leading to vomiting in pregnancy, think of any history of uneventful pregnancy, previous history of uneventful pregnancy. Suppose if hyperemesis is responsible, there is also a past history. डॉक्टर मेरे पहले बेटे के टाइम में भी यही हुआ, अभी भी यही हो रहा है, क्यों हो रहा है? Then that is hyperemesis. लास्ट प्रेगनेंसी में कभी भी नहीं हुआ डॉक्टर, मगर इस प्रेगनेंसी में बहुत उल्टी हो रहे हैं डॉक्टर. Then you should think something more serious. If there is worsening continuous headache from 14 weeks, increased nausea and vomiting, blurring of vision, then you think of any space occupying lesion is what you need to remember. If a pregnant woman has 3 years history of vague right upper quadrant pain with increased nausea and vomiting during pregnancy, doctor, last 3 years some kind of a pain doctor, right side I am having pain doctor, here doctor, and now a lot of nausea and vomiting. Think of cholecystitis, which is not uncommon during pregnancy, is what you need to remember. Now doctor, hormonal assay, one of the favorite question of the examiner. The patient is having a regular 28-day cycle but having infertility. What is the investigation of choice? Basically, doc, once ovulation happens, post-ovulation, corpus luteum is produced. Corpus luteum produces progesterone. That progesterone is the one which maintains the pregnancy. In few people, there is a luteal phase deficiency. They have a regular 28-day cycle, but still they are challenged by infertility. So you need to look for that luteal phase deficiency, and investigation of choice become day 21 progesterone is what you need to remember. In case of PCOD, polycystic ovarian syndrome, there is a reversal of FSH-LH ratio. There is a low serum progesterone. There is a increased testosterone and dihydroepiandrosterone sulfate. This is the typical combination of the hormonal milieu in case of polycystic ovarian syndrome is what you need to remember. Now, if there is a premature ovarian failure, how are you going to approach? Premature ovarian failure is my question to all of you. Typically, they have increased FSH, increased LH. So do 2 readings of FSH 4 weeks apart. So that is how you clinically investigate a case of premature ovarian failure. Now, how are you going to follow a molar pregnancy is a important question of the examining doc. So basically it is the urinary or serum beta HCG you need to do every 2 weeks till the levels become normal. That is how you follow the molar pregnancy. Abhi aa gaya favorite topic of the examiner, that is contraception. There are at least 100 points, doctor. Be part of our WhatsApp study group. There are 100 points. Your own 100-point list on topic like contraception. Why? Because entrance exam is there is no NEET PG, no FMGE, never it happens without a question on contraception. So that is the reason, doc, I urge you all that you become strong in the topic of contraception, have your own set of 100 points. You go to reading room, even if you are in washroom also, if your fellow classmate is on the other end of the washroom, you ask questions on contraception. That should be the mania of preparation, obsession of preparation, passion for preparation and to become a topper. Right, doc? So now let's quickly go. Young lady, non-smoker, regular partner. This guy is my roommate and my life mate. Hopefully, I'm going to marry him. So today all norms have changed, no? Living partner, NEET PG partner. There are so many partners in life. Married partner is lastly a partner. So what do you want to do for her? Combined oral contraceptive pill. Young lady, smoker, family history of DVT, pulmonary embolism, but a regular partner. Heavy periods. Then your intrauterine contraceptive device is okay, especially hormone containing newer generation like progestasert that will also take care of the heavy periods. But the partner should be a regular guy, the same guy with whom he is a partner in NEET PG on the wedding day and also the dad of your kids. Then intrauterine contraceptive device is okay. HIV patient want to have contraception. Barrier method, both male and female condoms. Young women with learning disability, heavy bleeding. Learning disability means she has a challenge to maintain compliance with your daily oral contraception. For her, you have to give injection Depo-Provera. 14-year-old girl, sexually active, then she want to have contraception, then combined oral contraceptive plus condoms. More than 35-year-old smoker, contraception, does not wish to gain weight, right? So, what is the best way? Intrauterine contraceptive device inserted within 48 hours of delivery after 4 weeks. Or after 4 weeks after delivery, anytime is okay, but within 48 hours of delivery or after 4 weeks is okay. Then, young lady, heavy periods, dysmenorrhea, want contraception. Hey God in heaven, what do you want to send? Combined oral contraceptive pill is okay. Rifampicin, taking combined oral contraceptive pill, they have a very high failure chance, hence additional barrier method need to be added, otherwise there will be a contraceptive failure. Learning disability want contraception, as I told you earlier, you can put a contraceptive implant like Implanon. Then breastfeeding women want contraception. Hey, the God of the heaven, what do you want to give? For her, progesterone only contraceptive is the best one. Lady presents within 96 hours of unprotected intercourse. She is on the 12th day of cycle. Then emergency contraception. And she is not interested anymore in the long-term contraception. Ella, that is ulipredol acetate in that given clinical scenario is the next step in management. Lady presenting within 36 hours of unprotected intercourse wanted emergency contraception. Levonorgestrel is considered to be the management. I am only giving you a few points. Only few points I have given you here. But my idea today is mainly to tell you what is the art of making a quick short notes of yourself, a handwritten notes, so that in the last moment before exam, no coaching is going to help you, doctor. Only your notes, or otherwise you outsource it to your senior or a junior. He will write a notes and you read in the last moment. That's also is okay for me, right? Or ask me, I will give you the handwritten notes. You can read that and revise in the last moment. But it should be a last moment revisable format of notes. And you should know what are those 15 to 20,000 points that should enter into your notes bundle that you are definitely going to do a revision in the last 1 month. Right, doctor? Now, menopause. Let's talk about menopause. 55-year-old history of cardiovascular disease. Essential hypertension is there but controlled by drugs. She is having tiredness. Body mass index is equal to 39. So, elderly female with history of cardiovascular risk factor, presenting with tiredness and body mass index. What do you want to do? Examiner is going to ask you. What is your answer, doctor? Calcium, vitamin D, reduce weight, weight-bearing exercise. That is your prescription and counseling. 54-year-old woman married 4 months ago. Of course, in India, married 4 months ago, 54-year-old is like a newspaper. West it is very common. But she complains of persistent dyspareunia, dysuria. Think of atrophic vaginitis in menopause. And what is the best treatment, doctor? Please write your prescription. Estrogen cream is considered to be the treatment. 50-year-old lady, perimenopausal symptoms. What do you want to tell her? Madam, oh madam, you are such a sweet girl. And these perimenopausal symptoms, mood fluctuations, hot flushes, they're very common. Don't worry, don't worry, don't worry. So you have to counsel her on her lifestyle changes. That's the only thing that you need to do. Not very aggressive, therapeutic, heroics are not really required. You want to relieve the symptoms of the menopause. But the patient said, oh no, I can't tolerate these menopausal symptoms. Do something about it, doctor. Right? Then you give hormone replacement therapy. Now, doctor, post-menopausal bleeding. Menopause is over. NEET PG is over. Are we still bleeding? Please don't bleed. NEET PG के बाद भी bleeding हो रहा है, तो it is carcinoma, underlying cause. So post-NEET PG bleeding, how are we going to manage? So post-menopausal vaginal bleeding, there is vaginal dryness, dysuria. One possibility is atrophic vaginitis. What is the next step in the clinical management, doctor? Papillary biopsy, hysteroscopic biopsy is the next step in management to diagnose, like Sherlock Holmes, the underlying cause for the postmenopausal vaginal bleeding is what you need to remember. Then postmenopausal shifted from replacement therapy, hormone replacement therapy to continuous therapy. Irregular bleeding is there. What is the main reason for that? From a replacement HRT, she moved to continuous HRT. And this hormonal change is the one which is responsible for her irregular bleeding. Simple. The change of the medication is responsible. So this is one of the favorite MCQ, doctor, of the examiner. Examiner will tomorrow give you a 52-year-old female shifted from replacement to continuous HRT. How do you want to, what is the cause? It is the change of medication. Then postmenopausal bleeding, always do ultrasound, look for the endometrial thickness. And the endometrial thickness is found to be 8 millimeter. What is the next thing you want to do? You want to do hysteroscopy. Now, menopausal bleeding, if hymen is still, okay, let's ignore this. Next question. Postmenopausal bleeding plus discharge. There is an obvious ulcer on cervix. What is the single most important investigation? Colposcopy. This is very interesting, doctor. This word, please don't forget. Intermenstrual bleeding. It is not postmenopausal. Between one cycle, another cycle, intermenstrual bleeding is there. That is very important clue. There is discharge. Previously treated with carcinoma in situ because she has undergone a pap smear earlier. But recent smear is negative. What is the next best step in the management? Examiner is going to ask you. So what is your answer, doctor? You want to do colposcopy. Very important to answer. Don't jump for anything else. So cervical cancer metastasis, how do you evaluate, doctor? CT, not MRI. CT. Endometrial carcinoma, MRI. That's what you need to remember. How do you follow up if it is the ovarian cancer? CA 125 is the way you follow the ovarian cancer. Now, doctor, postpartum hemorrhage. Let's talk about it. Very good to see 17 online students being very active. Once more, doctor, I am quite excited. Tomorrow, I am delivering a Learn ECG in 3 hours in Government Doon Medical College in Dehradun in Lecture Gallery 2. If you are from Dehradun, please come, let's all meet up. And early morning, 5 o'clock, I am flying to Dehradun from Hyderabad. And I love to see if inform your friends, we will all meet up, right? Now, doctor, one more thing I want to tell you. Starting from this Sunday, our 45 Sunday program, live broadcast is starting, along with the face-to-face class in Hyderabad. Morning 9 a.m. to evening 5 p.m. 9 a.m. to 5 p.m. we will be doing the revision of one subject every Sunday, a brisk revision. I not only preach you how to do a revision by yourself in the last moment in one day, I also know how to revise for you and direct you, make you sharp. Within 8 hours, how to make any subject revisable. That's most important feature, doctor. If you are able to consolidate, if you are able to recite Upanishads, that means you know the Vedas. So, like that. So, 45 Sundays and please welcome. So, our upcoming Sunday, 26th January, we have anatomy. Please call our helpline 9000868356. Just for 10,000 rupees, you get 360 hours of live session in 45 Sundays, interactive, live broadcasted, and the cheapest, most affordable coaching program that you will ever find anywhere in this world. If someone can teach you much cheaper than that, please let me know. I'll give you a free coaching, right? Now, doctor, postpartum hemorrhage, prolonged labor, post-delivery, heavy bleeding. What is the cause? Uterine atomy. Forceps delivery, profuse bleeding. Cause genital tear. It can be cervical, it can be vaginal, it can be perineal. 10 days post-delivery, heavy bleeding, uninvoluted uterus. Cause retained placenta. It's called secondary postpartum hemorrhage. After abruptio, patient is bleeding from the nose, bleeding from the ears, bleeding from everywhere, bleeding from the puncture sites. You should think of disseminated intravascular coagulation, which is not uncommon as a complication of abruptio if you did not treat it well, is what you need to remember. Now, the next part of the story, doctor, antepartum hemorrhage. Antepartum hemorrhage. How to write a notes, how to create a content which you can revise for yourself, your roommate, because your roommate is having 4 girlfriends or 4 boyfriends. He has no time at all to study. Whatever he is, the world may talk 10 things about him. He's your roommate, right? You love him so much. You take care of him. So you are that assistant to him or her and help her in the last moment to crack the exam, because he is your roommate all throughout the medical college. Whatever he is, you have unconditional love for him. So if you have to become professor in his life and help him to crack, you yourself should know how to have that consolidated list of points that you are going to do the revision in 10 hours every subject. One subject, 10 hours. How are you going to do that? That is the reason you should know the art and style and skill of making a quick notes, covering all the points at the same time and doing a revision in the last moment. That is what I make you the experts every day. Antepartum hemorrhage. 32-year-old smoker, 32 weeks pregnant, sudden onset of a severe unprovoked abdominal pain. That is, if it is painful, think of abruptio. 36-year-old preemie, 33 weeks pregnancy, painless bleeding. Abdomen is soft, fetus is lying transverse. You should think of placenta previa, painless. That predisposed to transverse line. 38-year-old paraphore, blood-stained, watery, foul-smelling discharge. Speculum examination is showing irregular cervix, ulcerated. You will think of cervical carcinoma. 22-year-old, the classical clinical vignette of examiner. 30 weeks gestation, bright red cervical bleeding, bright red, no pain, abdomen non-tender, fetal heart sounds are still audible, 20 weeks ultrasound unremarkable. She is at 30th week gestation. Okay, 30th week gestation. Now, transvaginal sonography in that scenario should be the investigation of choice. And general perspectivum examination will make you to exclude all other causes. That is the way you approach the antepartum hemorrhage. There is a failure to progress in labor and history of cesarean section, continuous pain over the area of the scar, increasing blood-stained liquid is there. You will think of scar dehiscence is what you need to remember. Now, doctor, you should know, like a parent, all causes of primary infertility. Primary infertility. What is primary infertility? No kids at all. Unable to conceive at least once. Whereas secondary means earlier had first child is okay, but second child is becoming difficult. So congenital adrenal hyperplasia, congenital abnormality of any genital tract, then Turner syndrome, testicular feminization syndrome. These are the things that should be there in your mind if there is a primary infertility. Now doctor, postmenopausal bleeding. Endometrial thickness is found to be more than 7. What is the cutoff for you, doctor, to not worry about? Thickness of 5. 5 is the cutoff. 7 is more than 5. So what do you want to do? Examiner is going to ask you hysteroscopy, endometrial biopsy, and Pipelli's endometrial sampling. Now, I'll give you some miscellaneous quick bullet points. Can you use sodium valproate and oral contraceptive together, or is it going to affect the metabolism and lead to failure? No sir, they can be used together. That's what you are going to tell the examiner. Hyperemesis gravidarum means immediately you should jump and say first line is IV fluid, second line is antiemetic. If this fails, if there's intractable vomiting, then IV hydrocortisone is considered to be the treatment. Asian primigravida present at 16 weeks. What is the most appropriate investigation for her? So always oral glucose tolerance test को भूलना नहीं. India primigravida presenting at 16 weeks means you should think of it. Diabetic mother, you do fetal echo. When will you do? 22 to 24 weeks. Why do you do? To see the structural abnormality. What is the structural abnormality? Are you expecting sacral agenesis and VSD is what you need to remember. Now what is the most common, very important question doctor, most common congenital abnormality that you see? Sacral agenesis. Now doctor, the physiological changes during pregnancy. Please don't forget, this is such a favorite topic, without that there is no obstetrics and gynecology. Is the streaming okay, doctor? Is the streaming okay, or are we cut off? Are you able to follow it? Can the online students can punch?